Welcome to Team Gut Girls, the podcast for anyone who's ever unbuttoned their jeans at 10 a.m., mapped out every public washroom in a 10-kilometer radius, or wondered why one bite of food can ruin an entire day. We talk about bloating, constipation, diarrhea, reflux, nausea, abdominal pain, histamine chaos, and all the quiet gut symptoms you're told to just live with. Join naturopathic doctors Dr. Whitney Baxter, Dr. Christina Carew, and Dr. Dominique Vanier. Your gut is talking, and we're here to help you translate. You're with Team Gut Girls now. Let's dig in.
And before we dive in, just a quick note. This podcast is for educational and informational purposes only. It's not meant for medical advice and doesn't replace working with your own healthcare provider. We're sharing general information, not diagnosing or treating anyone. Please always talk with your physician or licensed healthcare practitioner prior to making changes to your health, medications, or supplements.
Welcome back, listeners. I'm Dr. Dominique Vanier, naturopathic doctor, and I'm joined with my co-hosts and naturopathic doctors, Dr. Whitney Baxter and Dr. Christina Carew. And today we're diving into something that affects way more people than most of us realize, chronic digestive symptoms that don't show up on tests. So have you ever been told that your tests are normal, but you still feel bloated after every meal, nauseous, or like food just sits in your stomach for hours? You're definitely not alone. This affects a lot of people. Research actually shows that over 40% of adults and children experience what are called disorders of gut-brain interaction, or DGBIs. So we're going to refer to this group of symptoms throughout this podcast, mostly as DGBIs, because it's kind of long. These are conditions where the gut and brain are not communicating properly. So structurally, everything looks normal on scans and blood work, but the function, this is where it's key, the function of the gut, the function of digestion is disrupted. Let's first talk about what DGBIs include. They refer to over 30, we call them functional digestive conditions. In fact, there are 33 adult and 20 pediatric conditions. And so our listeners will probably know the most recognized one, which is IBS. Some people will have also heard of functional dyspepsia. This also includes functional constipation, which is like IBS constipation type, but it's constipation without the pain or discomfort. Similarly, functional diarrhea also falls under this category. Again, it's diarrhea without the pain or discomfort like we see with IBS, as well as functional abdominal bloating, and there's many other conditions. So today we're going to talk about, one, what these disorders actually are, two, why symptoms can be so real even when tests are normal, and what people can actually do about them. Okay, I think this is a good starting point, talking about what causes DGBIs. And as we know, and we've talked about before, there isn't just one specific cause or mechanism, but rather there are factors that can make these conditions more likely to occur as part of a larger biopsychosocial model. So of your experience in reading, what are some of these kind of characteristics or mechanisms that you guys know to be causative or involved with DGBIs?
I would say trauma is definitely one. So people will have a historical event that has happened, could be something recent, like a car accident, something that happened to them when they were really little. But it certainly is that brain-gut connection that gets interrupted. And that can also include things like, being hospitalized or having like a really regimented household, or maybe a mom that was like really strict because of dieting, things like that. Like all of that sort of embeds into our being, into our pattern.
Definitely. Yeah. Both physical and then also the emotional trauma side. Yeah. Yeah.
Yeah. It just it wires our nervous system in a certain way from childhood. And then they can just show up as pain later on, or even as a kiddo. Sometimes kids recognize, I did have a really anxious gut or sensitive tummy growing up. Other things like our genetic culture, depending on how we were raised again or where we were raised, that can play a role.
Yep. Things like infection, right? So we've got a lot of environmental factors beyond trauma, infection. There's interestingly parental behaviors, and I looked into this for another presentation I did. So how we interact when our child is having a disorder of gut-brain interaction, whether we're adding to that level of anxiety or taking away from it, will directly impact the outcomes of that condition for that child. And what we mean by that is referring to how many doctor's appointments they have, utilization of healthcare resources, which is, I mean, a very interesting part of what DGBIs are. Things like life stress will also be an involved mechanism, personality trait, like all of this it has to do with that biopsychosocial model. So it's often not just one thing. There's multiple factors. And then, there are also known risk factors. So a few of them would be the female sex, definitely a history of gastroenteritis. So if somebody has had some sort of GI infection at some point, that makes them at a higher risk of developing DGBI. What other risk factors are you guys aware of?
We talked about this early life stress event. So as naturopathic doctors, even medical doctors, they're asking your medical history and kind of walking through childhood and what it was like for you, what that looked like. History of abuse too. And then current perceived daily stress. Psychological disorders like anxiety, depression, or mixes of both. But that can all play into our nervous system's interpretation of these dysfunctions.
Thoughts, behaviors, sort of like somatic symptoms. So like revisiting thoughts or recycling thoughts like OCD or the sort of compulsive type behaviors. Certainly anything that affects our physical well-being. So having poor sleep, smoking, obesity, so abdominal surgeries, things where, our body has changed or maybe isn't operating the same way as someone else is.
Yep, absolutely. I think maybe it would be helpful for listeners right now to know what are some other examples, because there are really so many conditions. And every time I look through some of the research papers, I feel like there's more and more being added to them. So beyond the most recognized DGBIs like IBS, the ones that I had mentioned a few moments ago, we have a few more. So there's something called reflux hypersensitivity and functional heartburn. So those can manifest as GERD symptoms, but it's not actually true GERD. It has to do with the sensitivity to acid events and often to the volume of acid, where we can feel heartburn. Functional chest pain is one. There's 4 different types of IBS. What are some other ones, other DGBI conditions that you guys are aware of?
Yeah, so functional dysphagia or opioid-induced constipation, so things just not feeling like they're moving in any kind of way. Anything to do with any kind of rumination syndrome, so thinking about things or focusing on things so much that they don't happen. It's like you're like all day you're anticipating the thing and then it doesn't happen.
Hate that. If you look at so I'm sure you'll bring this up, but the Rome criteria and like how these DGBIs are categorized, it's a really nice presentation because the gut's along too with all these different functions. So really everywhere along the tube, there is a category of these DGBIs. So if you're feeling pain somewhere, like whether it's reflux or upper, middle, and lower, there's a section and a category on this. So biliary pain. If they can't find anything, so your gallbladder's been, you've had ultrasound, you've been assessed, you've had blood work, nothing's coming up, there is a DGBI called biliary pain. Yes. So it's always kind of nice to consider this and start to talk about this. And then functional anorectal pain. There's generalized abdominal pain as a category. There's so many more. And then there's into the pediatric categories of infantile colic, which is a DGBI. And yes, Dominique and I have littles. So
yes, we have littles. Yes, we have lots of things with colic.
Yes. Because they're feeling all these new sensations and gas and motility and movement, which is,
That's a really interesting point because so for our listeners, something called the Rome 5 criteria came out about a month ago, and they only update this criteria every 10 years. And so when we had started our podcast at the end of 2025, when we were talking about IBS, it was as it relates to only pain, but now they've actually changed the criteria in the last month and it's pain and discomfort. So anyway, maybe we should just do a separate podcast on that. But as it relates to DGBIs, there is a set kind of umbrella for criteria and how these things are diagnosed versus what other conditions possibly need to be ruled out. Okay, so let's jump into some myth busting. So let's talk about what some myths, we've heard about with DGBIs. I'll go first, and this is a big one. So myth number 1, bloating automatically means IBS. And that's certainly not true. There are so many other causes of bloating beyond IBS. But IBS, has kind of become somewhat of a catch-all diagnosis. And what's also interesting, again, like relating back to that updated criteria from a month ago, is chronic abdominal bloating. So in chronic abdominal bloating, so breathing pattern dysfunction is part of now the pathophysiology of chronic bloating. So what that means is it's no longer a nice to have breathing when we have chronic abdominal bloating. Like, we need to do it because it also has to do with how the diaphragm is moving. Other myths that you guys have come across regarding DGBIs?
Well, a lot of these include sensation of pain or dysfunction, like you talked about. So a lot of people think or talk about that DGI symptom means that there's a structural issue. And often that's what's bringing you to your doctor anyway, because it's fearsome to feel something or be worried that something's not working properly. Of course, if there's pain or like new onset loose stools, or you're feeling a lot of acid come up, that's worrisome. And what we want you to know is that there isn't a structure, it's a function. So it's altered perception, not your physiology. So there's a miscommunication between your gut and the brain for some reason that we want to determine. So if you think of it like this, your gut is a highway. So imagine tests and blood work and checking if the roads exist, but they don't tell us there's traffic accidents or miscommunication between the signals. So just the tests, just because these tests are normal, it doesn't mean that there's nothing wrong. So we just can't test for that.
Yeah, I'd say the big one around this is people that say I've had an endoscopy, I have a colonoscopy, I've had a gastric swallowing test. So they've had all these really diagnostic tools, but they're tools that talk about the structure, not the function. I think that people don't realize that piece.
Yeah, which is certainly helpful to rule out what can be like more serious issues. But I think sometimes people can go down this rabbit hole of if all these tests are normal. It doesn't mean we have to find that one test that's abnormal. And that's actually not how we want to think about it, because like we said, the tests can be all normal, but we still have a chronic digestive condition. Yeah. Myth number 3. So you can only have one DGB, and we know medicine doesn't work this way. Interestingly, about 30% of patients with one DGBI will have a second. And what we commonly see is there's a big overlap between irritable bowel syndrome and functional dyspepsia. About 55% of IBS patients also meet the functional dyspepsia criteria. Yeah, what that means kind of clinically, or for our listeners, is when we're trying to, make headway on one area, we can't ignore that there isn't something else happening at the same time. We don't just want to pigeonhole at one section of the gut, because that may not get us to where we need to be.
And I think that with a lot of our patients is that they come in the way the traditional medical system is taught, is one illness, one appointment, one solution. But the more patients that we see, we realize that there are so many clues in knowing more about the entire system and how it all intersects each other. Yep. Okay, so myth number 4, if I fix my microbiome, I'll fix my symptoms. That the microbiome is the key of all the problems. And well, it certainly is one of our mechanisms. I think that we certainly don't know enough about the microbiome yet. We are like a slice of pie in a big, big space in terms of what we know. It's part of the story, but there's all the things that make the microbiome function and grow, and signals and nervous system and how our body is responding and reacting, which is some of the mechanisms by which DGBIs are actually seen, at least currently, through the system. So you can have the best microbiome in the world and still have a function issue.
Yes, I know, which is so confusing.
It is confusing. And people want that test, right? Let's do a gut microbiome test. Like that's what's causing this. It has to be causing this. I've had everything rolled out. So it can be tricky, but kind of fun to educate people and to teach them the mechanisms at play here. And it can get kind of complex.
Absolutely. Yep. So a good transition into, let's talk about why symptoms can persist even after microbiome support, even when tests are normal. We want to talk about what these mechanisms are. And I actually educate patients often on this because, similarly, if we want to shift your microbiome, for example, we have to make sure we're looking at all the other mechanisms, right? So it's not just going to be one thing. One probiotic is not going to do it. So there are 5 key established mechanisms in DGBIs that tend to cross over all of them under this umbrella. We have had a motility disturbance at some point that is ongoing. There is visceral hypersensitivity, which we have talked a lot about in other podcasts, but that is where the patient or the person is subjectively feeling their gut so much more acutely, where we can have like pain signals amplified compared to somebody else who just ate the same food, just drank a glass of water and has no symptoms at all. The third mechanism is altered mucosal and immune function. And so that refers to things like an increase in pro-inflammatory cytokines like mast cells. We do talk a little bit more about that in some other podcasts as well. We've had an altered gut microbiota at some point. And again, we go back to what we just chatted about as it relates to what kind of caused this is we want to think about when we had gastroenteritis, that may have been just the light switch that went off and there was a shift in the microbiome after that. And the last mechanism is altered central nervous system processing. So let's dive into each of these. Maybe we'll tackle motility disturbance first. Yeah, Christina or Whitney, do you want to chat a little bit more about that?
I feel like this is our everyday.
Yeah.
So as Whitney alluded to, it's like one pipe. And so the pipe is kind of like an inchworm. So think of it that way, is that like each muscle contraction moves things down the pipe. And so the timing of things is really much affected by how our brain perceives it, how much time we wait to be able to eat, how fast we're eating, which medications that we're taking. Certainly the GLPs also affect this. So we have lots of other pieces of the puzzle that are affecting our motility and just our brain. Oh, that plays a big role. And so it's like, how frequent are those contractions? How fast do things move through the system? Does the volume move from one space to another? And so leaving one empty and making one full, or does everything kind of trickle through like a leaky faucet? And so those types of things can affect you where someone's getting like a reflux or burping, or feel like things are sitting in their stomach, or bloating or constipation. And they're all still motility disturbances. There's in different parts of the body. And some of the tools we have work in lots of parts of the body. So one thing can help many things, but it's not always that case. Sometimes it has to be more specific to the area that we're trying to impact. And sometimes fixing one area means that the one below it sometimes then poses a problem because it's still a pipe. And so, what do we see? We see bloating, we see vomiting, we see diarrhea, we see discomfort, we see heaviness, we see people that are don't want to eat because eating doesn't feel good.
Yeah, early satiety.
And then we definitely have a range of tools that vary from physical things to herbs and vitamins to medications that work in here. So if you are experiencing a motility disturbance, don't give up if someone's trying one thing, because there are lots of things that can help. It's just about understanding how is your body contracting. We unfortunately don't have a magic test to tell this one yet. Not through the whole tube. There's some areas of the tube that we can tell, but not the whole tube.
Good points. Yep.
You've been listening to this podcast. You know that Christina has the best metaphors.
I have one coming up, so just wait for it. I don't know if it'll be good, but
okay. You'll got it. Yeah. Love it.
You want to chat about the visceral hypersensitivity?
Visceral hypersensitivity, I always like describing to patients because they're like, oh, that makes so much sense. We talked about the early life factors and that biopsychosocial model of what went on in your early childhood and pulling it all together. Because this one means that there's an issue with pain sensitization. So your viscera, your gut, is just more sensitive to normal things that are going on. So it's if you feel bloated with water, or you just had a little snack and all of a sudden you're bloated and uncomfortable. So it's this sensitization in the DGBIs that changes the central nervous system feedback loop. So the gut and the brain just aren't communicating effectively. It becomes inappropriate or faulty, and that we see increased pain signals and then this pain disinhibition. So it's the pain is being communicated and not being told, you're overreacting. You feel the pain, you feel the bloating, you feel uncomfortable. So it's this concept that's really central to all disorders of gut-brain interaction, and not all of them present as pain. Sometimes it's like inappropriate bloating or reflux or some kind of function, but it's this result that causes the discomfort that's really distressing and can cause a lot of fear, and as it should. And that's what should prompt us to rule out all the other things that it could be and recommend that you do get the colonoscopies if it's indicated and all these other things, because we need to rule that out. But yeah, this is a big one.
And it can be a vicious cycle too, like that fear or that anxiety behind, oh my gosh, I'm having pain all the time now, can then actually worsen that feedback loop, which is really challenging, I find, because we want to just calm the system. And in doing that, yes, we have a bunch of tools, but it's also, we need to just calm how the brain is communicating to the gut at the same time.
I would say a big piece I see in here is nervous system dysregulation and muscle activation, meaning that body's just way more sensitive. So we can think about this like a concert. So you go to a concert and the concert is insanely loud, and it's fine because over time you get adjusted to the concert and you're playing the radio in the car on the way back, and you go in the house. The next day you turn on your car and you're like, oh my gosh, that radio is crazy loud. It's because you became sensitized to the noise in the concert and you didn't even realize how loud your radio was on the way home. But then once everything kind of calms down again, you realize like how loud that was. And so the same thing's happening in the body, is that there are other things that are adding onto this pile of this fire. And so something can feel really real in pain, but sometimes that's as a result of this fire that's already sort of.
It's a good one. Yeah. And that's maybe a good segue into like so we talked a little bit about that altered mucosal and immune function, which can refer to, what's known online as leaky gut, but medically that's intestinal hyperpermeability. So you want to think of it like we have like a cheesecloth. This is another metaphor. Another one after this, or like a window screen that's worn out, that has enlarged holes. So now we're seeing things come through that we don't, and the immune system is just freaking out a little bit. Things like proteins that maybe are larger than they should be coming through, other chemicals or other molecules are coming through. I like to think of it, that game cornhole that you play in the summer that has holes and you throw the beanbag in. There you go. That's your small intestine and it's not happy. So here we see that immune activation. There can be like low levels of inflammation. And we're not talking about like inflammation where we run somebody's C-reactive protein and we see the number high. This is not systemic inflammation. Although to make things complicated, you can have a DGBI and systemic inflammation at the same time. But this process, interestingly, will further contribute to visceral hypersensitivity, because we've got now altered receptor sensitivity in the gut. So, each mechanism can like kind of lead into the next here. We don't see them all in isolation.
And we have a whole podcast on leaky gut coming up. So
we do. That's right.
Stay tuned.
Dysbiosis. Let's talk about that. So this is point number 4 of these mechanisms. Anybody want to chat about that part?
Sure. Yeah. We were just talking about this before we started. We were talking about how, people with different diets and different screening tools will see different microbiota patterns. And certainly this has something to culture and diet as well. It's a huge component of it. And when we think about altering our microbiota, people often think about adding in more probiotics, and it's often a recommendation, which is generally kind of blanket given to people. But certainly probiotics are only 2 of our good bacteria categories, generally represented. There's many, many, many. So if anyone listening has ever done a stool test or done a biome or any of those kind of tests, they realize there's pages and pages and pages. And so certainly we only are just starting to know, but when we have dysbiosis, we generally see it as, less of the good bacteria and more of the bad bacteria. But in some cases, more of the good bacteria can also be a problem. So you can have too much of a good thing. Exactly. And so can the bacteria be playing a role? For sure, that's a potential possibility, but it's not the only possibility. And so if you have done work where you increased or updated or, replenished your microbiome and you still don't feel better, that wasn't the thing. It's just maybe there was more than the thing.
Yeah. And sometimes taking antibiotics on the flip side, you feel way better because now all of a sudden you're not getting the fermentation, gas production, which is normal. And so that visceral hypersensitivity is happy because you're feeling less things. So it makes sense to draw the conclusion of, it was my microbiome where, with these things, there's more than one pathway that's causing that discomfort.
Yep. And then to make it even more complicated, we know that a lot of patients, when they're having a flare-up of their DGBI, report cognitive challenges of just, I feel more tired, I got more brain fog. And then we can see improvements when we take antibiotics and I feel like I have more energy. That's strange, right? These kind of downstream effects.
Yeah.
I'll go over the last point. So altered central nervous system processing. We've talked already a lot about that. We know that the psychological stress can disrupt the gut, our gut pain threshold, impair mucosal, secretory, and barrier functions. Again, it's all kind of related to the things we've just spoken about. But what is interesting is we know from the research that strong emotions can also stimulate this contractility and induce defecation and diarrhea. When somebody has a DGBI and they're having a really highly emotionally charged day, let's say work is really stressful, we may be more likely to see them having to run to the bathroom. One example of this is if somebody even has anxiety leaving the house for work or leaving the house for an appointment, that acute stress on its own sometimes is enough to cause them to have to use the bathroom urgently. And that all has to do with this altered central nervous system communication between the brain and the gut.
And some of that is normal. It's normal to be nervous.
Yes.
It's normal sometimes that nervousness triggers intestinal problems, but it's also a bit different. I had a patient a couple of weeks ago who just didn't eat for 2 days before coming in because they were so worried they had to travel into the office that there wouldn't be a bathroom on the way. And so they just didn't eat, so they wouldn't have to. That's normal response. Most people are able to eat and still be able to attend appointments.
Yep.
Yeah.
And that's something, Whitney, you've spoken about a lot, right? Which is the consequence of having a chronic digestive condition into how we engage socially, whether it actually leads into ARFID or avoidant restrictive food intake disorder. And it doesn't even need to be a gut condition. I've seen this happen in patients who are really trying to manage their blood sugar because they've been diagnosed with diabetes and they won't take medication at this point, where it's, oh my gosh, is this one bite going to be affecting my blood sugar? And there's this fear response and this change in our relationship with food that can happen.
Yeah.
Weight loss.
Yeah.
Or
and
fasting or fasting or all the, whatever the rage is on some of these other podcasts.
So on the topic of gut-brain connection, let's talk kind of more about practical takeaways where we can talk a little bit more broadly, knowing that this isn't specific medical advice, but more broadly about what are some therapies that people can think about. So Whitney, do you want to maybe go over what some of these gut-brain therapies are?
Yeah, and we've seen a lot of these in the research more. CBT is a big one, so cognitive behavioral therapy. It's just really easy to study and set up groups and control groups, so it's always in the research of a recommendation. But there's a lot of groups that are in communities, and a lot of times they're virtual now, which is really nice. And for some, it's focused on anxiety, but they're seeing that this is really helping folks with DGBIs. And the gut-directed hypnotherapy. So there's more specific things to our gut now, and just deep belly breathing and guided meditation is usually what it sounds like, but it's just rewiring your brain to let you know that your body is safe and that these are normal processes that are happening. You're not in an alarm phase, like leaving the house, you're going to be safe. Or if you map out the bathrooms on the way, setting up tools to make your body feel safe so it's not just this panic and flush of loose stools. So there's a lot of tools, and anything that's consistent is what's been shown to be the most effective. So even if it's just diaphragmatic breathing, deep belly breathing every single night when you get into bed, if that's easy, perfect. It is really effective. And there's good videos on YouTube and a lot of tools that I've sent to my patients to be like, this is how easy it is. Whatever you can do, there's apps, and just to make it consistent can be really effective.
Mm-hmm. Mm-hmm. Yeah, it's the regularity of the implementation that's actually key there. Yeah. And then movement, we can talk about movement. So we know exercise definitely can target both sides of this equation, the gut and the brain. It can help with the natural contractions of the intestine. So it can definitely help with constipation by speeding things up. It can also move gas. So we can see sometimes a reduction in abdominal distension and bloating. And it does support more regular bowel movements. Because even for patients that have IBS mixed, so where they're jumping from both constipation to diarrhea, is we need to keep things moving. So sometimes we can have, actually the issue can be the more constipation side, where then the body is trying to move things on its own and we just jump back. Movement on its own can really help in that area. And then of course it addresses the gut-brain connection. So we can see a lowered sympathetic fight or flight tone. It does enhance the parasympathetic rest and digest activity over time. So some level, again, the consistency of exercise really important for people who do have DGBIs.
I would also say we have to think about not moving all the time. So sometimes we also see that people are like kind of always racing and running around, and so they aren't getting an opportunity for the rest and digest. So again, more isn't always better. It's like having a little bit of everything can be helpful. I had a lady who tried to do this, and she walked 20 kilometers a day. And so every day she walked 20 kilometers, which was amazing, except that she had to quit her job because she didn't have enough time to walk 20 kilometers a day. She had a regularity in her stool, and part of that was from all the walking. She actually had really hypercontracted muscle, which also created constipation. So like, it stops it out. Too much of a good thing can be too much. I don't know about you guys, but people are like, oh, I never eat like this. I always say it in front of you because they think that you guys, like, we have ideal eating. And I was like, you eat that stuff too.
Yeah.
It's like,
I don't judge here.
Everything has to come in moderation.
Yes. And like a shift in routine too. I always ask, with this flare, when this started happening, what changed in your life? Oh, I got more of a desk job, or started training for a marathon, or sleep is off, change in movement or habits, which happens in life. But just being able to kind of connect the dots for your own body is really helpful.
Mm-hmm. Mm-hmm. I would say a third area can be food triggers. And even though we've had a podcast, all food triggers are warranted, and we have ones about testing food triggers, there are things that be cause more sensation, and reducing or removing those foods or can be helpful. Also adding foods in. So sometimes when people do try things low fibers for a long period of time, they are going to get more in your stool because they don't have any fiber in it, or very limited fiber. And so it can also be the other way. Actually adding in some foods may also change your sensation and change the movement of things in the system, because there should be balance. And so taking all the carbs in your diet, which certainly has been a craze of late, or eating only meat, can still make you feel more food triggers, even though you've taken so many foods out, because your body is also still looking for those other nutrients to help things move and contract and move along the way. So always, if you're eliminating things, always have a reintroduction plan. I want everyone only eating 4 or 5 foods. Yes. That's why the price of celery is so crazy, people.
Yeah. It's really about the personalization aspect, and that relates to supplements too. And there are so many supplements. So we're, because we're now talking about over 30 conditions, and there are definitely some very good evidence-based supplements that can help. They are not the only thing. And so choosing a supplement to address, more the prominent mechanism could be like a good starting point. So for example, if somebody is having functional constipation or IBS constipation, we need to move the bowels a little bit better and support or help with that gastric emptying. We want to be looking more at like motility agents. But again, there's conversations around, do we need to address more of the pain aspects? So things like peppermint oil, definitely want to look at what we can use or add in regarding the brain-gut connection and just calming the nervous system down. That category of supplements is often referred to as nervines. And then for people that are having more of that reflux hypersensitivity or functional heartburn, we want to look at that category of supplements called demulcents. So they soothe the mucosal tissue. For example, slippery elm. There's so many of them. So it's really about that personalization aspect where you work with your practitioner and also discussing what are the most prominent or heightened symptoms that we're experiencing. Then, of course, the goal is not to be on supplements forever. They're just a tool. And then eventually, just like diet, we want to look at, can we have the lowest number in somebody's supplement regimen?
I would say we should also add medications into this category. So there are things in the medication world that might help some get further along faster to just feel more normal and calm some of the anxiousness around the pain and sensation that might be worth considering. And so it's only supplements that or only food or only diet restrictions, that there's lots of tools, and some of those include pharmaceutical medications, even for a short time.
And I'll just say too, if your doctor's recommended something and you just ask more questions about it, because now there is a category called neuromodulators, and what they are the anti-anxiety or antidepressant medication. However, they're a lower dose for a specific mechanism, which is working through the pain and visceral hypersensitivity. So even though they're the same medication, it's just a different mechanism that can really help DGBIs. So if a doctor has recommended this to you, but you're like, oh, I don't have anxiety, or just asking your questions around why are they recommending them and the dose and the plan, because they can be really, really effective if that's for your body.
Yep. Yeah.
Sometimes it's just like getting a reset in, right? You need a reset out of this loop that your body learned to start over again. It's no different than I did this the other day. I put my charger in a different drawer because, it makes more sense to be over here. And I keep going back to the original drawer and I can't find it. And I moved it. Where did I move it to? And so until my brain relearns that's not where I'm keeping it anymore, it's going to keep going back to those old patterns. And that's what some of these tools can do. They can help you get out of this pattern so that your body can operate in a less hypersensitive or hypervigilant way.
Mm-hmm. Mm-hmm. Yeah, those are really good points. So to close, we want to help people be able to talk to their practitioner when they feel like they're possibly experiencing a DGBI. But it's true that a lot of people will walk out of visits feeling like they maybe didn't quite say what they needed to say, or maybe they feel dismissed because their tests have come back normal, and then what? And you don't necessarily need to have the right words when talking to your doctor. You really just want a clear sense of what you're experiencing, what you want help with. A good plan, regardless of who your practitioner is, naturopathic doctor, family doctor, often co-managing somebody's care. But a good plan should feel collaborative and not dismissive. Based on your experience, what are some things that a person who thinks they're having a DGBI could say to their practitioner?
I've been noticing a pattern with my symptoms, like bloating after meals or loose stools if I'm nervous or if I have to go to work. Can we look at what might be driving that, like digestion or gut motility, and just ask them really specific things that you're experiencing? And I think the bottom line is my symptoms are really affecting me and concerning me. What's a good plan? Or do you have any recommendations on a referral or a dietitian or something, a tool?
Yeah, you can even say, do you have any other patients that are like this? And what are things that they have used or what are people that they have seen? Do you know of other people that might know more? I understand that this might not be your area of expertise. Giving them both an out, but then also asking them to actually think about it from who else could you see, can be really helpful. And they may not know. They may say, I actually don't know. I don't have any idea of who else you could see. But not just asking your practitioner, not asking your friends, asking your colleagues. Certainly there's a million Facebook groups that everyone who's listening to this podcast is a part of. Ask those people. They've already screened through the good practitioners and can say, these are the ones that have been able to help, or this is what this person told me, maybe look down this area or travel. Our healthcare is not linear. It's always changing and moving. And the only way we can get better ideas is literally crowdsource them. And we even do that. We do that with each other because we all see different things on different days and your brain is in a different spot. And someone's like, hey, remember that thing we did first year of naturopathic school? Maybe that actually would work. And they do happen.
Yeah, it's interesting. Yeah, you get to a point in practice, I think regardless of your profession, where it's like, there's so many people you see that are not textbook. It's just so much more, it's so much more complicated, and it's really not black and white, right? Oh, okay. So in conclusion, let's just do a quick recap. So for listeners, it's really important to know that normal tests do not mean that nothing is wrong. In disorders of gut-brain interaction, the issue is function. It's not structure. So, your symptoms are real, even if they don't show up on labs or imaging. And that should feel hopefully validating, because I think a lot of people under this category of conditions have historically felt invalidated because they have gone and seen their practitioners and their doctors have maybe said, yeah, everything's okay. You're all good. When they feel like crap. What about, let's do a few more recaps here. So go ahead, jump in.
So bloating isn't just about food. Clearly, we have many podcast topics on causes of bloating or contributors. So bloating can be driven by motility, that visceral hypersensitivity, breathing patterns, the gut-brain connection. Not always just what you ate, even though it makes sense to think that way. But hopefully we've kind of introduced you to some other ideas that could be causing it.
Yep, there's rarely one single cause and rarely also one single fix. So one problem is one solution, as much as we get to. There's no magic supplement that will make everything go away, but there might be a combination of things that make things a lot better. Mm-hmm. And every treatment layers that both you try and then later grow through or abandon in an effort because you've moved on. So it's that you are forever going to do this one thing. It's that in this moment at that time, you're doing something that hopefully.
Mm-hmm, mm-hmm. Yep. The microbiome is only part of the story, like we talked about, but it's not the whole story. So focusing really just on this area, like fixing your gut bacteria, can miss other key drivers of symptoms. So we want to take a step back and look at the whole picture.
Your gut and your brain are constantly talking, not necessarily in a language that we can understand, but remember that your stress, your emotions, the day-to-day, that nervous system is directly impacting your digestion. So this isn't just in your head. It's a true sensation. It's a true response that you're experiencing.
You have more treatment options than you think. So despite the fact you've heard from many people to have more fiber and take a probiotic, those are not the only gut support practices. There's lots of things, but physically, nutritionally, movement, strategies with medications and supplements, and lots of evidence for all of these depending on what you need to improve your symptoms.
Yep. And then lastly, our listeners, if you're experiencing any of this, you deserve a plan. So not just reassurance. And again, if you've been told everything is normal, but you still feel like crap, it's really reasonable to ask for next steps, ask for a second opinion, ask for a referral to a GI specialist, ask for a referral to a different GI specialist, work with your naturopathic doctor. Really, if there's just one thing you take away from this episode, because this is under the category of our bloating series, but bloating is not random. Chronic bloating is definitely not random. It is not something that you just have to live with either. You want to think of it like a signal, and there are ways to work with your body to improve it. Okay, thank you for joining us on this episode about bloating and disorders of gut-brain interaction. We hope you found it helpful because, as you know, better gut health changes everything.
Thank you for joining Team Gut Girls. Like, follow, subscribe, and share a podcast with friends you think will want to know more about their gut. You can also visit us at teamgutgirls.com for show transcripts and more information because better gut health changes everything. See you next time.